Hey guys, today we have a pretty quick, pretty straightforward PowerPoint. We are just kind of going through some common arterial conditions, and I guess you could technically call them pathologies, even though they're more so in the ballpark of physiologic processes. We're going to talk a little bit more about stenosis. We kind of talked about those a little in our last module. We're going to talk about the effects that exercise has on the body, and then we're going to talk about some common things that can happen when we have these systemic cardiovascular diseases and how our arteries are affected by those. So we're going to start off with exercise here. We know that when we are going through any sort of strenuous activity, any type of exercise, that's having an overall effect on our heart and our cardiovascular system. So we're initially putting a lot of increased responsibility on that outflow, right? Or that cardiac output from our heart. Just the lovely sounds behind me, an ambulance speeding by. So two things are going to happen in response to exercise, and these are normal things that we want to see happen in an average patient. We're going to have vasoconstriction and vasodilation. Vasoconstriction is going to do exactly what it says. It's going to constrict the blood vessels. So the blood vessels are going to narrow, and this is going to result from the contraction of that smooth muscle layer in the arterial walls themselves. So remember that middlemost layer of the arterial wall is going to be composed of all of those muscular fibers. So that's going to be responsible for the extreme narrowing of those blood vessels during vasoconstriction. Opposite of that, vasodilation, is going to be when our blood vessels start to widen, again, in response to that increased blood flow from exercise. So it's going to result from the relaxation of that same middle layer of the arterial wall. Exercise is going to induce an overall peripheral sense of vasodilation. So as we are running, our whole body, all of the vessels, all of the arteries in our body are going to expand. They're going to dilate to allow for more blood supply to get to the distal tissues. So this is going to lower the overall peripheral flow resistance, and it's going to lead to increased blood flow. So exercise is going to say to the arteries and the arterioles, hey, you need to relax, you need to dilate, and I need you to decrease the amount of resistance that you have for blood flow getting into that area. So I need more blood flow to get to those tissues because I'm exercising. I need to get more oxygen-rich blood to those tissues because they're going through that replacement process a lot faster. Right, exercising, we're using up more oxygen in our body, so those tissues are no different. They need oxygen, so they need increased blood flow while we're exercising. Now, autoregulation is going to be our body's way and kind of our body's response to exercise to really allow the vascular beds and tissues to kind of maintain a constant level of blood flow over a wide range of scenarios. So it's kind of like the give and take response between what exercise is doing to our body and then how our body is able to respond to that exercise. So it's going to say, hey, okay, I know that my tissue beds, my vascular beds are going to need a lot more oxygen, a lot more blood flow. So how can I maintain keeping that much blood flow in this area? And it does so by decreasing resistance, vasodilating, allowing more blood flow into that area. So that whole kind of give and take process is going to be known as autoregulation. Moving into some of the problems with our arterial system. So some things that are not going to be considered normal. Stenosis is one of the most common things that we see really in any type of artery, and there's a wide variety of stenoses. There's tons of different causes, tons of different risk factors, but basically it is going to be the abnormal narrowing of an arterial blood vessel. We can have venous stenosis, but we don't really care too much about it. We care more about an arterial stenosis. So this is when we have loss of that laminar flow, that stable flow. So we're no longer going to see a parabolic profile. We're no longer going to see that standard parallel travel of blood cells in that fluid as it moves through the vessel. So we're going to kind of lose that normal laminar flow in an area that is abnormally narrowed. We're going to see with a hemodynamically significant, you're going to hear that word quite a bit, especially in clinical, hemodynamically. So we're talking about the characteristics of that blood flow in that area. Hemodynamically significant stenosis can cause a decrease in our flow volume and in that overall pressure in that area. So of course, if we have a section of an artery that's more narrow than it should be, well, we're not going to get as much volume of blood traveling through that area. The degree and the occurrence of the blood flow abnormality produced by that stenosis is going to depend on a lot of things. So it's going to depend on how long, how narrow, and really how severe is that stenosis in that area. If there is some sort of plaque that's causing that stenosis, how rough is that surface of the plaque in the lumen of the vessel that that blood is trying to travel through? What is the rate of our blood flow, right? Is our patient undergoing exercise? Are they not? Are they kind of sedentary? Are they, immobile? All of those things are going to have a different rate of flow in those patients in general. What is the pressure gradient? So is there peripheral resistance beyond that stenosis? Is there something bigger going on beyond that stenosis that the patient has that's making the stenosis worse or that's making the stenosis occur? So all of those things are really going to have an effect on how much blood supply can get through that area. So the stenosis profile, when we're looking at a section of a vessel that is abnormally narrowed, we don't just say, oh, it's more narrow there. We have to look at it in different segments. So it's kind of like a detour on the highway, right? There's construction on the highway, there's a little detour. Everything is going to kind of behave differently in different sections of that detour. So same thing with the stenosis. We have to look at it proximal to the stenosis, at the stenosis, and beyond the stenosis. So just like when there's construction or there's an accident on the highway, you have things that are affected by that stenosis, by that accident, by that detour, that are before you even get to it, right? And then you behave differently as you're driving when you're going through the stenosis. And then after that stenosis, you're still behaving differently than the other two stages. So if we think about a car accident on the highway, when we talk about our next few slides, we'll come back to the detour reference, but we'll talk about a car accident on the highway. You're driving along, all of a sudden you hit dead stop traffic. Right? So you're not traveling as fast as you were. That's going to be with our proximal to stenosis, the flow frequencies are going to be weakened, right? So, whoa, that flow is going to kind of drastically start to slow down. At the stenosis, so now you kind of sat in that really slow flow, you made it to the location of the car accident, and now you're dealing with, maybe there's a lane that's shut down, maybe there's a disabled car, maybe it's a really bad medical emergency in that car accident. So there's a lot of different things going on at the stenosis. At the entrance of the stenosis, it's going to have this area where we have an increase in our Doppler shift frequencies. Remember that from physics, where it's going to result in spectral broadening and these abnormally elevated velocities. So the blood flow going through the stenosis is going to try to go through it really quickly, right? So we're going to see these areas of elevated velocities. Now, for us, when we're driving, when we're passing a car accident, we don't get to just kind of speed by it. But if you're like me and you see a car accident, my first thought is, am I going to see somebody on the side of the road? Am I going to see a medical examiner truck? Am I going to see blood on the road, right? So my first initial reaction is get through this area of stenosis as fast as I possibly can. So that's what the blood is trying to do in these areas. It's trying to get through that initial entrance to the stenosis as fast as possible. Now, because of this, we're going to start to see behaviors of that flow that are not going to be normal or effective. So we're going to see these eddy currents where everything is kind of swirling in different directions. We're going to see these abnormal jets, which are going to represent with our color flow, those elevated velocities. So we're going to see a lot of mixed behavior going on in the stenosis itself. Now, after the stenosis, you're driving past the accident, you made it through that area. Everybody is trying to get to where they needed to go, right? So we're going to see this rapid post-stenotic turbulence where everybody is whooshing out of that area. Everybody just sat in traffic for like an hour. So now we're all trying to make up for time. But Maybe some people are in the left-hand lane that need to exit off the right-hand lane. Maybe there are some people that got stuck in the right-hand lane that need to make it all the way over to the left lane. So we're going to start to see these patterns kind of still going everywhere while they try to figure themselves out. So we're going to see post-stenotic turbulence. We're going to see flow reversals. We're going to see those eddy currents still where that fluid is kind of going everywhere. And because of this, because the blood flow is not traveling in a nice organized fashion, we're going to have drastic energy losses with that. So distal to that stenosis, exiting that stenosis, we're really not going to have a strong waveform because it just used all of its energy trying to get through that stenosis and then going through that area of exiting the stenosis where it kind of was just like, oh, geez, like I just want to get out of here. Like I just want to keep going. So you kind of have like this little bolt of extra energy because it had to work so hard for so long. So here's what that is going to look like on ultrasound. On the left-hand side, we have a little diagram here. We kind of see that our normal blood flow is traveling through. This would be our renal artery, but we can see in that proximal region of the renal artery, we have a lot of plaque or atherosclerosis that's causing that narrowing of that pathway. So as it's going to travel through that region, this is a great example of that post-stenotic turbulence. So as it's exiting the stenosis, it's kind of going every which way. It's kind of a little bit confused. It doesn't really know what to do. And then we eventually will get blood flow to the kidneys, but it's going to be reduced because of how much energy it had to expend to get through that region. Here we have two good color and Doppler pictures of what a stenosis could potentially look like in different segments. So here in the middle, we are going to see this sort of at the stenosis, within the stenosis, where the waveform doesn't look really chaotic. I mean, we have a little bit of flow reversal because we're seeing both colors representing flow going in both directions here. We see a little bit of turbulence right in this region. If we look closer at the lumen of the vessel, we have an area of plaque here, another area of plaque here. So we're sampling that stenosis kind of within that region. We're getting a really, really, really elevated velocity. If we look at our Doppler caliper right there, 407, basically 480 centimeters per second. We don't want to see anything over 125. So that right there is a extremely abnormally elevated velocity, and that right there is going to tell us, especially in addition to the visualization of the plaque, that there is a blockage going on in that area. Now this picture on the right hand side, this is sort of showing exiting the stenosis. So if the stenosis were here in this region, we're still seeing sort of that bidirectional flow with some of those flow reversals, and then we're sampling it. I kind of drew right over it, but we're sampling it right kind of at that distal end of the stenosis where we're now able to visualize all of this chaos, all of that turbulence. When we Doppler it, we're getting true flow reversal because we're getting a waveform below the baseline. We have drastic spectral broadening here. And as we measure those velocities, they're still very elevated. Hard to see on here, but we're getting a peak systolic velocity somewhere in the 800s and an end diastolic velocity somewhere in the 600s. So we said we don't want to see a peak systolic velocity greater than 125 centimeters per second. We really don't want to see an end diastolic velocity greater than 40. And this is in the 600s. So this is really saying that this blood flow had to fight really hard to get through that super narrow pathway. So collateral effect. This is going to be our body's natural way of responding to a stenosis. The main issue with the stenosis is that you're not getting the adequate amount of blood supply to the tissues that you need. So your body has to respond and account for that. So this is the body's natural way of creating detour paths around a blockage or around a stenosis. So this is normal in response to stenosis formation. So at rest, when we're relaxing, we're kind of laying down, the total blood flow is going to be fairly normal, even if we have a stenosis or a total blockage of an artery. And this is going to be due to the collateral formation that our body creates to compensate for the decrease in peripheral resistance due to that blockage. So let's look at our diagram here. We have a normal artery kind of just traveling along, minding its business. Oh, it gets right to this region here, and it starts to learn that when it gets to this area, it knows there's a blockage because the distal tissues beyond that aren't getting the blood supply. Look at this vessel. It's no longer red or pink. It's white. It's not getting anything. So proximal to where that blockage is occurring, the body is going to create another pathway to allow for blood flow to go to those distal tissues another way. Same thing here on this right-hand side. This is going to be a bigger example of how our body would do that and very much bypass that blockage. So don't look at this as like normal or collateral, because these are coronary arteries. So we're just gonna do that there. So arterial obstruction is going to alter our flow in collateral channel. So of course we're not going to see like textbook standard flow in these detour paths, because they're not, the body just had to form them in response to another problem. So they're not going to be like standard typical arteries. They're going to be a little bit variable. So we may see potentially increased areas of velocity. We could see abnormal waveform pulsatility. So, we would expect to see as a triphasic waveform. We may now see it as biphasic in that collateral vessel. We could see little areas where the flow direction kind of gets reversed. And that's because the body's still kind of trying to figure out this new pathway. And then we're going to see increased flow volume, which is going to be a good thing for the patient, because that with that increased flow volume, they're still going to get the oxygen that they need from that arterial blood. Okay, moving into some of our specific conditions here. So when we're doing physical exams, the arterial system is very sensitive to the visualization of the patient. So patient physical exam and physical evaluation is very important when we're looking and evaluating the arteries. This is kind of the bane of every vascular ultrasound tech's existence with every ER physician out there, because it seems that sometimes they just order exams without having even looked at the patient. Sometimes physicians will order a DVT study on a patient to rule out a blood clot in the venous system, when in reality their toes are, black or blue. And that's not a venous symptom. That is an arterial system. So why do I keep saying system? Symptom. So we want to be aware of how certain arterial conditions appear on our patients. That way we're not confusing it for a venous issue or vice versa. So the skin color, temperature, the appearance of the skin, that all is very important. So the color of the patient's skin, if it's pallor, it's going to be pale, indicating a very deficient blood supply. If it's rhubarb, it's going to be red. These are going to represent dilated vessels. Typically aren't seeing too many red legs with arterial conditions, especially with an arterial stenosis, because if we have a stenosis, the vessels aren't dilated, they're constricted. And cyanosis is going to be a big one for us. So this is going to be when the legs or the feet turn blue, and this is showing that there's a concentration of deoxygenated hemoglobin. So we're only having, we're not getting enough oxygenated blood to those tissues, so it's starting to turn blue in response to the high levels of deoxygenated blood. Temperature of the skin, anything arterial is going to usually be cold to the touch. Anything venous is going to be warm. When you think about why that is, our blood supplies heat. If we're not getting enough blood supply to our toes are going to be cold. Lesions, these are really, really painful, really uncomfortable, especially if they're arterial lesions or arterial ulcerations. These usually are stemming from a bigger problem. So uncontrolled diabetes has a very big effect on our arterial system, especially down in our toes. Gangrene, that can kind of wreak havoc if it's uncontrolled or untreated. So these lesions are very, very common, more so in the arterial system than they are in the venous, although we do know that there can be causes for venous ulcerations as well. Capillary filling, so we want to see the capillaries refill within a certain amount of time, meaning that if you squeeze a certain section or you compress an artery to the point where that skin loses color. When you release that compression, you want to see that color return to that skin within a reasonable amount of time. So if that time takes longer and longer and longer for the flow to return and the color to return, that's going to indicate that there's a decreased arterial perfusion. Perfusion is talking about the rate of blood flow getting to those tissues. Elevation changes also are going to have an effect on that arterial system. So if we lift up our foot, we are going to see it turn white. If we put our foot down, we could see it turn red. This is something that a lot of conditions, and not just cardiovascular conditions, can cause. So we don't rely too much on elevation changes when we're looking at the arterial system. We really are looking at color, temperature. Those are kind of like our main two, and then secondarily the lesions and the capillary filling. We're also listening for a pulse, so that's going to be our palpation. We want to hear and feel nice rhythmic arterial pulses with the heart contractions. Any decrease in that pulse is going to indicate that we're not getting enough blood supply in that area. And then we typically will grade that palpation or that pulse. So we'll give it on a scale of 0 to 4. If the scale is 0, that means we don't feel any arterial pulse. And if it's 4, then we feel a nice, strong, rhythmic heartbeat. Aneurysms can be palpable and bounding. So aneurysms can sometimes confuse physicians when they're listening. So if a physician is listening to your aorta, they hear a nice, strong, beating artery, they're going to think that everything's fine because there's no stenosis in your aorta, but little do they know there's a big old aneurysm in there. We also can feel a vibration or a thrill over an area where a patient has had a fistula, where they have a dialysis access site, or if they've had a known stenosis in that region too. So when we hear anything other than that normal, rhythmic, strong beating, we need to question that. And we also can't just say, oh, I heard a normal, strong, rhythmic beating, therefore everything is fine, because that could be an aneurysm. We also have auscultation. This is also known as when you're listening for a bruit. That's going to be an abnormal noise that we hear. It's going to be most common in the carotid arteries, but we can listen for our aorta, our femoral, and our popliteal arteries. Some risk factors of arterial diseases. Diabetes is going to be the most common. Hypertension, hyperlipidemia, smoking, increased age, any family history, and men have a stronger prevalence of arterial diseases as well. If you kind of look at the previous risk factors, men are more likely to have these issues as well. Men are more likely to be smokers. They have higher cholesterol levels, they typically have hypertension, and they're more likely to have diabetes as well. So chronic arterial occlusion, it's exactly what it sounds like. So you have this blockage of your artery for a long period of time, and it's either not responding to treatment or the patient hasn't sought treatment, and it's going to have an overall effect on a lot of aspects of that patient. So it's not going to be, just one little area that's blocked, and it's fine because the body made it collateral. And, yeah, that's all fine and dandy. The body made it collateral. They're getting blood flow to those tissues. But who's to say that those detours are going to last forever? When they replace a bridge, they tend to build a temporary bridge next to it, but that temporary bridge isn't built to last. So you have to figure out the root of the issue, why this is happening. So some signs and symptoms of these chronic occlusions. Claudication is a big symptom that we talk a lot about in the vascular world. Claudication is when you have muscle pain during exercise and it subsides with rest. It's going to result from inadequate blood supply getting to those muscles, especially when it's needed during exercise. It's going to have predictable behavior, and we're able to kind of estimate the disease, the level of the disease by where the symptoms are occurring. So if you are going for a walk every night after dinner, and every night while you're walking, you get a pain in your left ankle, chances are you may have claudication. Now, this is not for anybody who has they sprain their ankle, or they have a shin splint, or their muscles are sore. This is different. This is not orthopedic pain. This is not, pain from a nerve based ongoing disease, a neurogenic disease. This is pain because you're not getting blood supplied to your tissues. But if you go for a walk every night and you have pain at your left ankle, the level of where that blockage is occurring is going to be above that left ankle. So you could have the blockage in your calf, you could have it in your knee, you could have it in your thigh. But if you have pain in your knee, at the level of your knee, chances are the blockage is not going to be at your ankle. It's going to be up higher in your thigh, in your pelvis. So claudication is going to be kind of like that first sign and symptom, kind of the more mild sign and symptom that something is going on. There is pseudoclaudication where people think that they have true claudication, but it's really kind of more of an orthopedic issue. Maybe they have arthritis, maybe they have fibromyalgia. Those things can create pain during exercise and also subside during rest. Sometimes those things also don't subside during rest. True claudication will always be painful during exercise and subside during resting periods. Ischemic rest pain, this is kind of like that intermittent sign and symptom now. So claudication, but like, a little bit more advanced. This is when we're going to have more severe symptoms of that reduced blood flow. This is going to occur when the limb really isn't being used. So now we're no longer having pain just while we're exercising. We're still having pain when we're sleeping or laying down. And then kind of the final symptom is going to be tissue necrosis. So this is when we have death to all of those surrounding tissues, that level of where the blockage is. And as we know, it's going to be caused by deficient or absent blood supply to those areas. So kind of like a 3-step pathway to potential, tissue amputation. Now, acute arterial occlusion, this is a little bit more worrisome than chronic arterial occlusion, and that is because with chronic arterial occlusion, you've had that for a while. It's kind of progressed slowly. Your body has had time to create collateral networks, to create detour paths to get around that area and blockage. With acute arterial occlusion, your body has not had time to bypass that area of narrowing. So all of a sudden, you get this total blockage of an artery and your body has no other pathway to send that blood to those distal tissues. So this is going to be emergent. This is not going to be something that we wait for the body to form pathways for, that we put the patient on blood thinners. No, you are figuring out what caused this occlusion. Surgically, they're going in, they're removing that blockage. So with this, you want to be looking for the 5 Ps: pain, pallor, pulselessness, paresthesia, and paralysis. Pain, pretty obvious. Pallor, pale. Pulselessness, not feeling that bounding rhythmic heartbeat. Paresthesia, numbness. Paralysis, can't move it. So all of these things, if you have that, get yourself to an emergency room. Arteriitis, this is going to be when we have inflammation to the arterial wall that is going to lead to potential thrombosis of the vessel. It's going to happen more likely in the smaller vessels, a little bit further away from our heart, so kind of in those peripheral vessels in our fingers, and maybe in our distal wrist, in our distal ankle, maybe down in our toes. Typically, this is not something that occurs spontaneously, but this is very common in people who smoke. Smoking wreaks havoc on our arteries. It really does. It creates a lot of plaque. It creates a lot of inflammation in the body, and the arterial system is very susceptible to that. So really going to be common with smokers, typically in young men younger than 40. They're going to have breast pain and ischemic ulceration. So this is not something that you're going to confuse for claudication, because this is not happening in response to exercise. This is still going to be painful while the patient is resting, and then we're going to start to see tissue death because of the lack of blood flow getting through these really small, plaque-filled, inflamed arteries, and we're not going to get as much blood flow to those distal tissues because of that. So those tissues are going to start to die off and be replaced with ulcerations instead. So here's a nice picture kind of showing how thick and how affected those arterial walls have become. So this is all kind of like thrombus formation along that posterior wall. Same thing with this anterior wall. So all of that chunk and just inflamed wall and thrombus settlement along the wall is really causing a narrowing of that vessel. And when we put color on, you can see it's a very thin string of fluid getting through that region. Definitely not as much as those distal tissues need. Next, we have atherosclerosis. So this is actually the most common arterial pathology. Is when we have the thickening, hardening, and loss of elasticity of our arterial walls. Different than arteriitis, that was the inflammation of the walls. Atherosclerosis, it's going to have an effect on pretty much all of the layers of the arteries. It's really going to be based off of what is that patient's diet, what are their lifestyle habits, what does their environment look like. So all of those things are going to lead to the formation of this plaque. And plaque is kind of the general term that we give for it. It can be lipids, it can be blood products, it can be fibrous tissue, it can be calcium, right? So we have different types of plaque, different densities of plaque, depending on what it's made up of. Either way, it's going to have an overall effect of weakening the walls. It can also cause embolism, thrombus, right? So if any of those areas of plaque break off, of course, they can travel. We're also going to see mural wall irregularities. So we're going to see the settlement of all of these kind of, plaque products in the arterial wall itself. And the vessel is going to become narrow in response to that. Risk factors: smoking, hyperlipidemia, family history, hypertension, diabetes, poor lifestyle, arterial wall stress. All these are going to be risk factors for developing atherosclerosis. Some vessels are more affected than others. So the more common sites are going to be at the bifurcation of the carotid, where our vessels are originating proximally. So kind of like in that common femoral artery area, kind of where like our renal arteries come off of the aorta, the superficial femoral artery, which we know we like to just call our femoral artery, and then the trifurcation of the calf arteries in the back of the leg, just to the pop site. So smoking, hyperlipidemia, family history, those are going to be the big risk factors with atherosclerosis. But of course, hypertension, diabetes, lifestyle, all that is going to have a general effect on it as well. What does it look like on ultrasound? So again, we said it's going to depend on what it's made up of. Some plaques are made up of more calcium, some are made up of more fats, some are made up of more blood products. So it's really going to kind of vary. You want to make sure that you are not playing with your gain and your TGC settings too much, because sometimes when you see a little irregularity along the wall of a vessel, you're thinking to yourself, well, okay, I know my vessel should be perfectly anechoic, so let me just turn my gain down. When in reality, now you're making it look like there's no pathology there. And then same thing, you could be scanning a normal artery and your gain settings could be too bright, that now you've made it look like there's an irregularity in there. So always be aware of what does the rest of your vessel look like, what's an appropriate level of gain to keep your picture at. But for the most part, we're going to see some sort of echogenicity within that vessel. Gravity has an effect on atherosclerosis. We spend a lot of time laying down, so a lot of plaque is going to gather along the posterior wall of a vessel. You can see that from this picture here at the carotid bifurcation, that the arrows are pointing to the plaque accumulation in that posterior region of the bifurcation. You also want to make sure where you're looking in vessels that are very tortuous, vessels that are very kind of twisty-turvy, curvy, kind of like squiggle worming all over the place. Those areas may be easier for plaque to accumulate because it's kind of like a little pocket for it to settle in. So all things that we need to be aware of when we're looking at the vessel. We're giving a great evaluation of the wall. Yes, we want to make sure we're following our protocol. Yes, we want to make sure that we know how to actually Doppler an artery, but you need to know that you're also looking for these minute appearances. Arterial embolism, anytime we have any kind of motion of an accumulation in an artery. So we have an obstruction of a vessel by a foreign substance or a blood clot or any type of plaque formation. It could be solid, liquid, or gaseous. Gaseous embolisms are really only going to occur from a surgical procedure. We don't really just produce gas in our cardiovascular system. So if you have any kind of interventional procedure where air could potentially be introduced into your arteries, that's when we would have a gaseous embolism. But usually if this is going to happen organically, it's going to be either a solid or a liquid. Most common cause for an arterial embolism is going to be a solid type, where a small piece of plaque is going to break loose and travel distally until it is stuck in a much smaller vessel. So our toes and our fingertips are going to be most affected by an arterial embolism. So it's still concerning, it's still worrisome, but we almost are more concerned about an embolism in the venous system, because if an embolism breaks off of a vein, it's heading to the heart, regardless of where it is. The end point of the venous system is the heart. So it's literally headed to have a heart attack. Whereas the arterial system, it's only going to head more distally. It's only going to travel away from the heart. Now, I say that it's not completely harmless. There are still situations that we need to be aware of. And it's most severe when we see plaque in that carotid, in those carotids. Because if a piece of plaque breaks off the carotid, yes, it's still traveling away from the heart. So we don't need to worry about a heart attack for that patient. But the end point of the carotid is the brain. So you don't have to worry about a heart attack, but you do have to worry about a stroke. We're fortunate that a lot of embolisms happen posterior to the body, kind of like not posterior, inferior in the body. So we see a lot of plaque in the leg arteries. We see a lot of plaque kind of in the abdominal aorta. So we're fortunate that a lot of plaque could embolize down to our toes, right? And that's not to say that we don't care about not getting blood supply to our toes, but if it were up to me, in my choice, I think I'd rather pick a blood clot in my toes than in my brain. So things to all kind of think about in the bigger picture. Blue toe syndrome, like we said, that's kind of the end point for a lot of these arterial embolisms. It's going to result in toe ischemia, so total lack of blood flow to the toe, which is therefore going to result in tissue death because it does not have oxygenated blood flow getting to it. So a lot of these patients will end up having to get their toes amputated. Aneurysms, this is a review. So dilation of all arterial walls, very commonly caused by atherosclerosis. Symptoms of this, we should remember how to measure an aneurysm. So I'm not going to spend too much time on these. This should all be a review for you guys. Pretty straightforward. You can kind of just read right through these. Okay, so a little bit different than an aneurysm, we have a pseudoaneurysm. So pseudo is always going to kind of, be the word false. Pseudo means false, not true. It's going to be when we have a defect in the main arterial wall. So typically in that innermost wall that is in contact with the blood, and then sometimes also with that middle layer. Usually that outer layer, that adventitia, is still going to be intact with a pseudoaneurysm. But that intima, definitely that intima, and sometimes that media can be disrupted, could have a defect in those two layers. So it's not going to involve all three layers. It's when blood from an artery can escape through that defect in whichever wall or walls is affected, and it's going to travel kind of outside of that normal arterial pathway. So blood is still going to kind of circulate within that area, right? And there's going to be like this little hallway that connects the main artery to this pseudoaneurysm. These don't really occur spontaneously. The patient has to kind of be going through something in order to have a pseudoaneurysm develop. Typically, it's going to be from an interventional procedure. So interventional radiology, it's a type of X-ray procedure. They use the femoral artery as an access point for a lot of procedures that they do on the heart. So when you're doing an invasive procedure of the heart where you don't want to cut the patient open, right? Like we're trying to not be doing open heart surgery. So they're trying to do more and more through these interventional procedures where they can fix what's going on in the heart, they can treat what's going on in the heart without having to cut the patient's chest open. So they do so with these different points of access. They kind of send these skinny tools, these small tools and tubes up into the heart through distal sites. So how are we going to get into the heart? It's going to either be through an artery or a vein. So when we're doing an arterial interventional procedure, they use the common femoral as an access point for a lot of their equipment. So they will, literally insert catheters, insert tubes, insert tools into that femoral artery and push it all the way up through the common iliac arteries, through the aorta, all the way up through that aortic arch, down into that heart, and do what they need to do. So because we have kind of artificially punctured that artery in the leg to be able to get all those tools up into the heart, that's already going to put and kind of create that defect in those arterial layers. So very common to see pseudoaneurysms form after a patient had an IR procedure done. Any other type of procedure that can involve the arterial system in that area is, of course, going to weaken that wall. Any kind of trauma to that area can weaken that wall and create that defect. So these things aren't happening spontaneously. It's not something that people are born with. It's really kind of something that is happening because of something else that happened to the patient. What does this look like on ultrasound? I love scanning these. These are what we call the to and fro pattern, or the yin yang sign. So you literally see your main artery here. You see your connecting pathway, or your neck, and then you see your pseudoaneurysm here. Now, you may have seen at Rhode Island Hospital, or maybe even at, maybe even at Miriam, you can actually treat these under ultrasound, where they go in and they use compression of the transducer, and they are able to inject thrombin. So they are actually able to go in and artificially clot this area of the artery so that it's, not sending out blood flow to an area that doesn't need it. And it's cool to watch on ultrasound. So they have you find the pseudoaneurysm. They insert a needle into the area of the neck that has the medication that's going to clot it off. And then as they're inserting it, you're pushing down with a ton of transducer pressure to get it to collapse and prevent it from opening back up again once it has that clotting medication in it. So very interesting to watch under ultrasound. Aortic rupture, again, pretty straightforward. You guys can read through this on here. Usually it's going to occur from an aneurysm. Our aortas don't typically just decide to burst for no reason. So it's usually going to be from an aneurysm of some sort. So moving into our dissection, or our dissecting aneurysm. Dissection is when we have a small tear of that inner wall that's going to allow blood flow to kind of travel between the two layers, the intima and the media. So this is not really like a pseudoaneurysm. Pseudoaneurysm has like a pathway that's created in that defect of the wall, and then it's going to be contained in that outer layer of the adventitia. This is going to allow for kind of like a tear to happen down a segment or down a specific distance of that artery. It typically will meet, it can meet back up with the distal part of that artery, like this top picture is showing, but it usually doesn't. So it kind of just accumulates and accumulates and accumulates, kind of like this picture on the bottom does. Of course, when we have that happening, and as that blood is accumulating and accumulating, it's weakening and weakening and weakening those walls. So these patients are going to be having extreme chest pain and back pain. They are going to go into shock because they essentially have blood loss, even though it's a contained blood loss. It could be caused by hypertension, severe chest trauma. So we can see these with car accidents. We typically really will only see these with car accidents because it is such a drastic thing that occurs. But again, any patient who's undergone some sort of cardiac procedure, any patient who has really severe uncontrolled hypertension, it's all going to have an effect that could potentially create this tear in that intimal wall and lead to this sort of bleeding. Here's what it looks like on ultrasound. So here we can see in sagittal the flap. This is going to be the intimal flap here. So we can assume that the dissection occurred up in this region because it's allowing for some of that blood flow to travel down through all of this area. In transverse, we can see here's our intimal flap and here's our blood collection. Because a motor vehicle accident is the most common cause of a dissection, we are mostly only going to see these in the thoracic aorta. So again, not something that we're going to like really stumble upon during an abdominal exam, but just because it occurs in the thoracic aorta doesn't mean that it's just going to like only occur in the thoracic aorta. So if it occurs in your thoracic aorta, it could tear and split all the way down into your aorta, into your iliacs. So when we're doing an abdominal exam, if we see a flap like this in sag or transverse, first of all, we want to make sure it's not a clot, but second of all, we really want to make sure that it's not a dissection, because that's a little bit more, in the moment, severe and emergent than an embolism would be. Both of which are severe, but a dissection, that patient really can drastically take a turn for the worse very quickly. Next, we have coarctation of the aorta. So this is something that most people are, if they have it, they are born with it. So it is a congenital anomaly. It's where we have the abnormal narrowing or kind of like the constriction of the thoracic aorta. It can affect the abdominal aorta, but I have never seen or heard of anybody who had a coarctation of the abdominal aorta. It's typically going to happen kind of in that arch region, so therefore in the thoracic aorta. Signs and symptoms of this, we're going to see these in kids. Typically they're going to present with symptoms that kids shouldn't be presenting with. They're going to have hypertension. They are going to have lower extremity tissue loss and a lack of blood supply to those lower extremities. And, we really shouldn't be seeing those arterial symptoms in a child. On ultrasound in utero, we should be able to see this during our fetal ultrasound pictures, but sometimes depending on where it's happening, if it's happening in that distal thoracic aorta or it's happening in the abdominal aorta, it's not really part of a standard anatomy protocol. So sometimes it can be missed in utero, but again, these symptoms are going to present in children, very surgically repairable. So this is not something that these kids have to worry about for their whole life. Next, we have popliteal artery entrapment syndrome. This is going to be very common in runners. So typically young patients who are pretty active, it's where the head of their gastrocnemius muscle at the back of their calf gets really, really big and bulky. And the fibrous bands of that muscle actually kind of create this intrinsic pressure on the popliteal artery. It's going to result from development of potential thrombosis or embolism in that area, or even an aneurysm from that pressure of the gastroc muscle. Signs and symptoms, like we said, typically young men who like to run, symptomatic arterial occlusion. So we are going to see people having that claudication where they're having pain during exercise, but it relaxes when they are resting. So again, something that can be surgically fixed. They kind of just go in and remove that area of the gastroc muscle so that it's not placing all of this extra pressure on that popliteal artery back there. Next, we're going to talk very, very briefly about AV fistulas. We may come back to this throughout, kind of closer to the end of the semester, but there is a lot of information that goes into AV fistulas and also how to scan them. It's a very precise and tricky exam to scan. We also have kind of organic AV fistulas that can kind of just happen spontaneously or traumatically, or we can have intentional AV fistulas that we surgically place in a patient, depending on what's going on with them and why we need to do that. So an AV fistula is going to be, we're going to kind of just think of it right now in terms of the natural sense of an AV fistula. These can either be congenital or traumatic, so you can either be born with these or it can happen in response to some kind of accident. It's going to be the abnormal connection between the very high pressure arterial system and the very low pressure venous system prior to the capillary beds. So this is where the artery and the vein are communicating with each other prior to where they should be. We know that they only should be communicating with each other in the capillary beds, so anything other than that is going to be considered an AV fistula. There's also another broad term that we can use for those abnormal communications or abnormal connections, and that's going to be an AVM, arteriovenous malformation. We will kind of touch upon that as we go through this semester as well. So like we said, abnormal connection between the arterial system and the venous system somewhere other than the capillary beds. It can affect the main arteries and veins or the collateral arteries and veins, depending on if our patient has collateral network development due to a stenosis or an occlusion. It can cause anatomic and hemodynamic changes, so it is going to have an effect on the blood supply and drainage of both the artery and the vein. A peripheral AVF, so meaning it's in the distal areas of the body, we're going to have an increased risk of tissue death to those areas, so ischemia. And if it's located close to the heart, so if we're talking about, you know, the aorta and the IVC communicating with each other pretty proximally up in that abdomen, we're going to have a really high risk of heart failure, because if you have an abnormal connection that's happening so proximal to the heart, to the origin of our cardiovascular system, the heart's not going to be able to function properly, because it's not going through the normal steps and the normal give and take of heart contraction, sending it out through the arterial system, waiting to receive it back from the venous system. It's happening too close. It's happening too close to home. So we're going to have an increased risk of heart failure if we see an AVF happening near the heart. And Raynaud's phenomenon, this one's always kind of interesting to me. This is a vasospastic disorder. There are two different types of Raynaud's phenomenon. So we have primary and secondary. Chances are at least one of us has primary, and this is going to be where it's a hereditary condition. It's a benign condition with a good prognosis, but it's typically going to be in response to extreme cold. So Raynaud's in general is going to be a condition that exists when we have symptoms of kind of like this intermittent digital tissue death. So basically, we go through these short periods of time where the tissues in our fingertips don't get any blood supply. And that's typically going to be due to either really cold temperatures or really stressful situations. So the skin color is going to change. It's going to get very, very blue, typically very blue or very white, and some patients can get very, very, very red. This is like bright cherry red. So primary, like we said, this is going to be something that is very common in young women, usually going to be due to extreme cold temperatures, but within a short period of time of getting back into a warm environment, your flow returns, everything's back to normal. So it's kind of a very temporary situational thing. Secondary Raynaud's is where we consider this to be obstructive. So this is where the ischemia is constantly present. So really, no matter what we do, no matter how warm it is, how relaxed we are, we kind of have this constant state of constriction of the arteries in those fingers. So kind of have this constant tissue death. That is going to be a very serious condition, because if we have prolonged tissue death in our fingers, then we would have to potentially amputate them due to tissue necrosis. So here are some examples of really the variety of what Raynaud's can look like in some patients and some people. So some very white fingertips, some very red fingertips, very, very blue fingertips. So very interesting. I'd be interested to know if you guys feel like you have this, especially living in New England with these cold winters. If you have any questions, please don't hesitate to reach out to me. Again, you have information from the spring semester about aneurysms, so that should be a little bit of a review here, but please make sure you know that. Please make sure you understand the differences amongst those aneurysms. Please make sure you know how to measure aneurysms regardless of what type they are. So again, any questions, just reach